Hello everyone, am I audible?
Yes, I can hear you.
Okay, good, thank you. Um, Hello everyone, welcome to this workshop. This is our very first meta-analysis workshop, so welcome. We let's first introduce Dr. Muaz, who is our senior mentor. If Dr. Muaz could please turn his mic on and introduce himself, and then we can get on with the workshop. Dr. Muaz, are you here? I don't think he has joined us yet. We can uh, do his introduction later. Let's just start. Okay. We're just going to get right into it. We're not going to waste any time. So what is a meta-analysis? A meta-analysis is a type of study that combines results of similar researches with statistical methods. So basically, we will be pooling, when we're conducting a meta-analysis, we pool results and data from different studies. So we could have we need at least 3 studies of original studies, and we take data from those 3 studies and we're going to pool them, and we're going to analyze that data in a software that we're going to get on towards tomorrow. We're going to teach that software tomorrow. Today is just the basics and data extraction and stuff. So we're going to take data from those studies and we're going to extract that data. We're going to enter it into a software, and that software is going to statistically analyze that data, and then we can use that analyzed data to draw conclusions and results from that data. So basically, it combines results from multiple studies to provide stronger evidence. It is part of a systematic review with a quantitative component. It increases statistical power and resolves inconsistencies. What is the importance of a meta-analysis? The findings of a meta-analysis are applicable throughout the world, because the studies that we're going to include in our meta-analysis are going to be studies that have been conducted over the world. It's not, we could have use studies that are specific to an area, but normally when we're conducting a meta-analysis, any researcher goes for like a wide range of studies, and every study that has been conducted on a topic has to be included in our meta-analysis. So this can potentially have guideline changing impact. So every meta-analysis that you're getting published or even working on is going to uh, have a lot of value. So it's going to actually count towards a change in the medical guidelines. Thus, it is at the highest level in the hierarchy of evidence-based medicine. This is the research hierarchy. So there's different kinds of researchers, right? Let me just hide this. So there's different kinds of researches. For example, there's editorials, there's mechanistic studies, case reports, cross-sectional case control studies, cohort studies, randomized control types, and at the very top of the pyramid is systematic reviews and meta-analysis. So this is a very, very important kind of research, the most important, some might say. Why are SRMAs conducted? SRMAs stand for just systematic review and meta-analysis. These synthesize results from multiple studies, hence providing comprehensive insights into research questions. So we could have a research question. We're going to formulate a search string for it. We're going to search up all the data and all the studies that we have on that topic. And all those published studies on that particular topic, we're going to extract data from those studies, and we're going to analyze that data. And that data and that analyzed data is going to give us answers to our research question. So then they enhance reliability and validity, enabling informed decision making in clinical and policy settings. As I said, these meta-analysis, they can have guideline changing impact. So basically, the results that you draw from a meta-analysis, they could potentially change clinical medicine. Pooling data in a meta-analysis increases the overall sample size, which enhances the statistical power of a study. So why do we pool studies? Because one study could give us results, but those results could be just a matter of chance, right? So if we have multiple studies, on the same topic, and we're using data from all of the studies and we're statistically analyzing it. There's no subjectivity in this. It's all objective. It's all done by a software. We have nothing to do with it. We're just extracting data from studies that have already been published. So this enhances the statistical power of the study in the sense that because we're using multiple studies, the sample size, the population that we're conducting that study on is a lot bigger than the study than the population that one single study would focus on. This leads to more reliable and accurate results. Additionally, combining the data helps address inconsistencies across individual studies and provides a comprehensive summary estimate. Obviously, because you're taking data from so many studies, the matter of chance thing is really out of the picture. You can't expect something to be a matter of chance if multiple studies are reporting the same thing. What is the difference between a narrative review, a systematic review, and a meta-analysis? These are all different kinds of study designs, right? These are all reviews. So the difference between each kind is basically summarized in this topic, in this table. So a narrative review is basically a broad overview of a topic, often descriptive. So basically you're going to handpick studies of your choice. You could use 3 studies, you could use 5, you could use as many as you want. And you're going to take data from that, not exactly data, not like numbers and stuff. You're just going to use information from those studies and you're going to broadly overview a topic. It's often descriptive. So this is qualitative only, and there can be considerable bias because you could skip information that probably doesn't go with the flow of your study. So this is there is considerable bias in narrative reviews, and it's basically just a general summary without quantifying findings, and therefore this has the least value of these 3. Systematic review answers a specific clinical question or a research question. So all the studies that have ever been published on a topic are reviewed and then an opinion is formed. So basically, this is also qualitative, but you're using all the studies. You're not handpicking studies. So this has a lower bias compared to narrative review, but still considerable bias. And this produces detailed and reproducible summary of evidence. So this has more value than narrative review. And then there's meta-analysis. This is the best kind of study, if you might say. Meta-analysis basically statistically combines results from multiple studies. So basically, meta-analysis is a continuation of systematic reviews. During your research careers, you will come across studies which will be systematic reviews, but nobody will have analyzed it, nobody will have meta-analyzed it, and that's an opportunity for you because you can use that topic and you know that it has all the studies ever published on that topic, and you just need to take that data, put it into a software, get the results, and you have a meta-analysis on your hands. So that's what a meta-analysis is. It basically takes data from all the studies ever published on a topic and it pools them together in an analysis, and this is quantitative. So we're talking numbers, we're not talking opinions and stuff. Hold on, give me a minute.
Your slide is stuck, Dr. Manahe. It's not moving on.
Hello, Dr. Tomas.
Okay. Hello, everyone. Can everyone hear me?
Yes.
Okay. So, everyone, my name is Dr. Mohammad Moaz Mushtaq. I'm a graduate of King Edward Medical University. I applied for this year's match in US and got matched in Rochester General Hospital. So, I'm an incoming PGY resident at Rochester General Hospital. Right. So, I was actively involved in research during my time at my medical school. and even now I'm involved in research as well. My research is mainly focused on systematic review and meta-analysis. Uh, I had an opportunity to do other researches as well, but I always thought that systematic review and meta-analysis are the best form of researches because, first of all, number one thing is you do not need a lot of people for these researches. Secondly, you can even complete a systematic review and meta-analysis in 3 to 4 days if you're very good at it. So the more you learn, the better you will become at it. So it has a very great reward potential as compared to the other studies like cohort studies or the cross-sectional studies that would take 6, 7, 8, 9 months to complete. So systematic review and meta-analysis take a lot less time to complete as those studies. Thirdly, the quality of your studies is gauged by the number of citations that get on your paper, right? And as Dr. Minahal was saying, that systematic review and meta-analysis, they combine a lot of studies, scientific studies together. So the authors of other papers and other researches and even universities love to cite your paper for different kind of therapeutic applications. So all of those things help you a lot in building a better profile, and that will ultimately help you in a lot of way as it helped me. So if you are USMLE aspirant and you want to match at a good place, so these meta-analysis and systematic review will play a very important role. Because believe me, I had 12 or 13 interviews during my journey, and the people who had similar stats as me, so I had a 276 in step 2, 260 in step 3. And those people who had a similar score to me, they had very less amount of interviews as compared to me, just because they did not have as much of a research as I did. And secondly, the main research I did was focused on systematic review and meta-analysis. So I was able to complete them quickly and uh, do a lot of them and get a good amount of citations as well. So this systematic review and meta-analysis helped me a lot at that time. So again, during my interviews at different US institutions, these this research has helped me a lot because my interviews were mainly focused on them, and the people who were taking my interviews were really impressed with the researches. They were very basic researches and they were very easy to do, but the main thing was I knew how to do meta-analysis. So I think this is a very great class for you, and I really applaud all of you for joining it. And I would be here with you along with Dr. Manahil and Dr. Ahmed and Dr. Maheen to provide you the best possible guidance as we can on systematic review and meta-analysis. Because the more you learn to it, you will know the greater you can get from it. There is a lot of reward. It will help you in getting more competitive residencies as well. If you want to go into dermatology, if you want to go into radiology, if you want to go into surgery, if you want interventional radiology, even if you want OBGYN, ophthalmology, all of these fields require researches. And believe me, the other kind of researches that are there, like cohort and cross-sectionals, they are very difficult to do at our level because you need a lot of funding and a lot of support from a lot of different authors which are very well known in their fields. But in case of systematic review and meta-analysis, it's very simple, it's not abstract, it's very objective. So it's basically maths, and if you get good at it, you can get a lot of them to be published. And as a result of them, you can easily get different kinds of research positions, which are very hard to get right now in US. But again, if you have good mm, amount of researches, which again is possible online systematic review and meta-analysis, because in systematic review and meta-analysis, you can get them published quickly. So that is the thing that will help you a lot in your research positions. If you want to go into residency, it will help you go directly into residency as well. And the third thing that a lot of people ignore is that if you have a good amount of researches, like I have 12 or 13 researches, I have 25 or 30 plus citations, it will help you get a green card also, right? So I have a friend of mine. He have almost 70 or 80 researches, and all of them are meta-analysis, and he has 800 plus citations. And as a result of that, he got a EB1, a green card, which is an Einstein-based category of green card, and he got that green card in 10 to 15 days, right? So researches will help you in that also. And so the more citations you have, the more better it will be for you. I had a friend who had a really low score in step two and step three as well, but he got mashed due to having more researches. So all of the best for this session. We will be here for with you, Dr. Minahi, me, Dr. Ahmed, and Dr. Maheen, and we will help you as much as possible. And this journey with you will go a long way. And I will try. So this is not just a class. It's not just a session that you will attend and you will learn and then will part with. This this is NextGen USMLE, and here we are building a family. So we'll try to build a family with you. We will have networking with you. We will help you develop better networking connection in the US with different researchers. We will get you connected with different researchers in the US. And ultimately, that will help you get residency spots in the US if you want that. So I hope we form a long bond over this time. And this session may be very useful for you. And you get a and you become a very prolific researcher. So that's it. Does anyone any question for me?
Thank you, Doc, for your informative introduction. I'm just wondering how long, for example, you need to finish like one of these meta-analysis usually.
No, type your question in chat and I can answer it there. And your voice break a bit. Can you go?
Can you hear me, Doc?
Yes, I can.
Yeah, thank you for the informative, introduction, and we hope you the best of your you know, future work. And also, I like your way of discussion, and I appreciate your help. I'm just wondering how long it will take for the meta-analysis usually to be, to be done. Thank you.
Okay. So you're asking how long will it take for the meta-analysis to be done? So thank you. First of all, thank you so much for your kind words. Regarding the meta-analysis, if you are good with it, if everyone in the groups, when you do the meta-analysis, we will delegate the task to different people in the group. And if everyone is good with their tasks, the meta-analysis will take at max 15 to 20 days or maximum 25 days. And then we will try to get it research as early as possible, to get it published as early as possible. So maybe the publication will take another month or so. And so we are looking at a total time of 2 to 2.5 months and implementations. Okay. I hope that's answered your question.
Thank you, Doc. Thank you. Appreciate it.
Hello, Doc. Hello.
Hello,
Can you hear
hello.
me? Yeah, hi,
Yes,
Doc.
I can
Thank
hear
you
you. Can you hear
for
me?
your. Yes, Doc, I can hear you. Thank you. First of all, thank you for your encouraging words and your awesome classes. I just want to know that in this meta-analysis, like how many groups will there be, and how many participants will there be for in each group? So that's what I want to know.
Okay, so for each meta-analysis, there will be 8 to 10 people in each group, right? So 8 to 10 people will be participating in a group because in order to get as much in order to get as much efficient as possible, we need at least 8 to 10 people. So 8 to 10 people will be in a group. So the research will get published with a people of 8 to 10, and so that is how we're gonna do it. And the more amount of work you put in the research, the more your name will be on the top.
Okay, thanks, Doc. Thanks.
Okay, so thank you so much for the very nice introduction, Dr. Moaz. We will have a Q&A session towards the end, so don't worry if any of your questions are pending. You will get a chance to ask your questions towards the end of this workshop. I was told that there was a technical difficulty and I was not sharing my screen, so I will share my screen again. And please let me know if you guys can see it. Is my screen visible?
Yes.
Okay, thank you so much. Back to the start. We talked about what a meta-analysis is. It's basically when we combine the results of similar researches with statistical methods. So we have a topic, a research question basically, that we want to conduct a meta-analysis on. We're going to take that research question, we're going to form a search string out of it. This search string is basically the string of words that we're going to put into our databases, where we're going to search for studies, which the studies that are based on that topic or that research question. We're then going to take those studies, we're going to extract data from those studies, we're going to pool that data, and we're going to analyze it on a software, and that analyzed data is going to be our answer to the research question. We're going to discuss it in our meta-analysis. So that's what this means. This figure very efficiently shows what we do in a meta-analysis. We take different studies. I put 3 studies because 3 is the minimum number of studies that you need to conduct a meta-analysis, and we pool those results. So a meta-analysis combines results from multiple studies to provide stronger evidence. It is part of a systematic review with a quantitative component. So a systematic review only does the qualitative part. And if we want to take it forward a step, which is the last step, because meta-analysis is the best kind of research, so to say. So because it adds a quantitative component, because we're talking numbers now. We're not talking subjectively. This is just pure objective. And this conducting a meta-analysis increases the statistical power and resolves inconsistencies, which means that basically, since we're using multiple studies, the sample size or the population that the study is being conducted on has vastly increased. And the matter of, because some studies could report outcomes, and if we're looking at a single study, we could think that maybe this outcome was a matter of chance. But if we're using multiple studies and they're all reporting the same outcome in the same way, there is really no way that we can associate that outcome to a matter of chance, because it's been reported by multiple studies. Importance of meta-analysis: the findings are usually applicable throughout the world, not limited to a region, because we're using all the studies published on that topic. Every single studies to date that have been published on that topic, we have to include them in its meta-analysis. This is what makes a meta-analysis so superior to all other types of analysis and reviews. This can potentially have guideline-changing impacts, which is self-explanatory, obviously. And this is at the highest level in the hierarchy of evidence-based medicine. This is the research hierarchy. Basically, there's different kinds of researches, and the quality goes somewhere like this. The one at the top, they're the highest quality ones, and the ones at the bottom are the lowest quality ones. So basically, editorials, case reports, cross-sectional case control studies, as we move up the pyramid, the quality of evidence increases, obviously. Systematic reviews, as you can see, is at the top of the pyramid, which means that this is at the top of the research hierarchy. This is the best kind of research that you can do, basically. This is very valuable. Why are SRMAs conducted? Because they synthesize results from multiple studies, providing comprehensive insights into research questions. They enhance reliability and validity, because obviously we're talking numbers now, and they enable informed decision-making in clinical and policy settings. Pooling data in a meta-analysis increases the overall sample size, which we've spoken about before, which enhances the statistical power of the study. This leads to more reliable and accurate results. Additionally, combining data helps address inconsistencies across individual studies and provides a comprehensive summary estimate. So any kind of bias or any kind of errors that may have been found in one study could not have been found in every single study that we're including, right? So if an outcome is being reported by every single study, it is a very reliable outcome and we can depend on it to be true. So there's three different kinds of reviews that we come across. So there's a narrative review, a systematic review, and a meta-analysis. A narrative review is basically when we handpick studies, and it could be any number of studies. I could use 3 studies, 4 studies, 5 studies on a topic, and I could take information of my liking and I could put it together into one comprehensive composition, and I could get it published, and that would be a narrative review. So it would be qualitative only. But the con of this is that there will be considerable bias, because I could knowingly be skipping out information that maybe does not go with the flow of my narrative review. So I could skip that, which is a con for narrative review. So basically, it's the least value review of these three. Then we have systematic reviews, which answer a specific clinical or research question, which I spoke about just now. We have a research question that we want to conduct a systematic review or a meta-analysis on. And then all the studies that were ever published on that topic, we have to look for those studies. We have to conduct a literature search. We have to take those studies and we have to review every single one of those studies, and then we can form an opinion. This again is qualitative only. This is not quantitative, because we're still not talking numbers. This has a lower bias compared to narrative review, but still a higher bias compared to meta-analysis. So this produces detailed, reproducible summary of evidence and has more value than a narrative review. And meta-analysis, the best of the best. This basically statistically combines results from multiple studies. So all the studies, data from all the studies ever published on a topic is taken, it is pooled, and it is analyzed. So this is statistical and this is quantitative. So there's the least amount of bias, because numbers don't lie. So this has the least amount of bias, and a meta-analysis has the most value. So this provides pooled effect in the forms of OR, RR, and MD, which we will talk about soon. OR is odds ratio, RR is risk ratio, but these are effect sizes, which we will talk about later in this slide, in this presentation. So sometimes you will come across a systematic review which will not have been analyzed. So basically, it will be a systematic review, but not a meta-analysis. A meta-analysis is just one step forward of a systematic review. So basically, you've already pooled all the studies into a systematic review. You just need to take data from those studies and analyze it, and you get a meta-analysis. So some people stop at a systematic review, which their loss is your gain, because you could take that systematic review, you could extract data, meta-analyze it, get it published, you have a meta-analysis. So half your work is already done. Steps of conducting an SRMA. SRMA stands for systematic review and meta-analysis. Please let me know if I'm going too quickly. I will slow down. First of all, you need, obviously, before conducting any type of research, we need a topic. So the first step of conducting a meta-analysis is to decide on a topic. Then we conduct a systematic search on all the literature available for that topic. As I said just now, we need all the studies that have been conducted on that topic to date. So we're going to conduct a systematic search on multiple databases, at least 2 databases, and we have to come up with all the studies that have been published on that topic. Then we're going to extract data from those selected studies. We're going to assess the quality of the included studies, because not all studies are going to be good quality studies. Some might have missed a certain kind of population. Some might have been confined to a certain age group. There could be different kinds of biases. So we need to assess the quality of the studies, and we need to account for the low quality ones. We have to mention it in our meta-analysis that this so-and-so study was a lower quality study for these reasons. And then we analyze that data, we write the manuscript and submit it to a journal and get it published. The first step is topic selection. For topic selection, we need to make a PICO. We need to formulate a research question, and the format is called a PICO. P stands for population. This is the population that we're going to conduct. This is the population of our topic, right? So if I want to conduct a research on, for example, the health effect of smoking on older people, right? So my population is older people. My intervention is smoking. Intervention is basically what you're adding externally. Control is what you're comparing against, and you won't always have a control. In some cases, you might not have a control as well. And then the outcome. So like I said, I want to conduct a study on the health effects of smoking on older population, right? So older population is my population. Intervention is smoking. Control is non-smokers basically, and outcome is health effects. So population defines a condition or a disease, including explicit diagnostic criteria and setting of interest. This could be age, race, sex, community, hospital, outpatient, anything. You get the point, right? And interventions could be risk factors, they could be exposures, or they could be interventions. So basically any pharmacological intervention, any surgical intervention, any exposure like smoking, genetic mutation, anything basically of that sort. Risk factors, as I said, and then comparisons. C stands for comparison. Comparisons could be placebo, they could be standard therapy, standard surgical techniques, normal way of living, stuff like that. And outcomes, basically the outcomes that we're trying to study. Outcomes can be of two types, broadly, categorical and continuous. Categorical outcomes are also known as nominal outcomes. Outcomes or variables, same thing. Same thing. So categorical outcomes are non-numerical variables. So they're not numbers, they're non-numerical. These can be of two types. They could be dichotomous and they could be non-dichotomous. Dichotomous means there's only two options. For example, yes, no, alive, dead, pass, fail, stuff like that. And non-dichotomous have more than two categories. For example, blood type. For example, hair color. For example, eye color. They could be more than, so these are categorical. They're not numbers, but they're not dichotomous. They don't only have two options. Someone's blood type could be A, B, O. Someone's hair color could be blonde, brunette, ginger, whatever. Eye color could be brown, black, hazel. You get the point, right? And continuous is numerical variables. So basically, for example, height, and then weight and BP. These have an increment, and these are numerical, and they're not dichotomous. They're numbers. So obviously, there's a wide range of them. These could be with decimals or without. So we've got two kinds of outcomes, categorical and continuous, and then there's two kinds of categorical outcomes, dichotomous and non-dichotomous. So we've studied about PICO. This is a very small exercise. I want you all to please formulate a PICO for this topic. The efficacy of inspiratory muscle training in improving clinical outcomes in heart failure patients. I'm giving you 3 minutes for this. Please write it down in the chat box.
What was your question, please? I missed that. What was your question?
I want you guys to write a PICO for this topic. The efficacy of inspiratory muscle training in improving clinical outcomes in heart failure patients. This is my research question. I want you to formulate a PICO for this. So P stands for population, I stands for intervention, C stands for control, and O stands for outcome. I have the answers up ahead, so if you're not able to do this, don't worry about it. I'm going to discuss this.
Population is the heart failure patients.
Okay, good. We have a few answers. Let's, should I wait? We'll wait one more minute and then we'll move forward.
Intervention is the training, respiratory muscle training.
Yes, good. Okay. This is the PICO. The population, some of you have gotten it right, most of you have gotten it right. So the population is patients with heart failure. Intervention is inspiratory muscle training. Comparison is usual care, placebo, standard therapy. And outcomes are basically clinical outcomes, improved or not. So kudos to all of you who got it right. Ramesh, Khadija, Muhammad Asadullah, Rani Ala. Very nice, excellent. Okay, moving forward. If any of you want to compare, population is patients with heart failure, as we can see over here. The efficacy of inspiratory muscle training in improving clinical outcomes in heart failure patients. This is our population. The intervention is inspiratory muscle training because we're testing its efficacy. So efficacy of inspiratory muscle training. The control is standard therapy, standard exercise. This doesn't have a very specified control. And then the outcome is efficacy or improvement and clinical outcomes. Okay. Moving forward, because arguably the hardest part of a meta-analysis is coming up with a topic, because every topic you come up with, you're going to conduct a literature search and you're going to find out someone's already done a meta-analysis on it. So these are a few tricks to come up with the topic. So basically, every single one of us almost knows which field we want to go into, right? So someone could want to go into neurology, someone would want to go into cardiology, radiology, etc. So you're going to go to the journal of your interest and you're going to find out the recently published original articles. What are original articles? Original articles are basically articles which have been done on humans. They have an intervention. They basically are testing an efficacy compared for the outcome for an intervention. Basically, we're going to study about original articles in the coming slides. So you're going to go to that journal of interest. You're going to look at the recently published original articles, which could be controlled trials, cohorts, cross sectionals, any kind of original article, and you're going to go on to PubMed or Google Scholar or any other major database, and you're going to check if a systematic review or meta-analysis has been done on that topic. If a meta-analysis has been done, you're going to check when it was published, because most times you can update an already published meta-analysis, which in this case we did update a meta-analysis. So you're going to check if a meta-analysis has been published on that topic. If it has been published, you're going to check when it was published, and if there are any new articles, original articles which have been published after that meta-analysis, that you can maybe add to that meta-analysis and basically get your own meta-analysis. So if no SRMA has been published, you have to see, because you've already found one published original article and you know that there's no meta-analysis published on it, you're going to have to come up with two other original articles, because for a meta-analysis, you need a minimum of 3 original studies on that topic. So this is how you do it, right? This is probably a bit confusing. You basically need a minimum of 3 original studies. So you're going to check if you're going to look at one study and you're going to think, oh, I want to do a meta-analysis on this. You're going to go on to PubMed. You're going to check if a meta-analysis has been done on it. If a meta-analysis has been done on it, you're going to check if it can be updated with a newer article. And if a meta-analysis has not been done on it, you're going to check if you have 2 more original articles that you can pull the results from, and then you can conduct a meta-analysis on your own. Original studies are studies with actual patients.
We can't hear you.
I'm sorry, I got disconnected. I don't know what happened. Apologies for that. Is my screen visible to everyone?
Yes, right now.
Thank you. Okay. So original studies are studies with actual patient data. In systematic review and meta-analysis, we only pool data from original studies, as I've said before. To conduct a meta-analysis, we need to pool data from all the studies ever published on that topic. For this reason, a systematic review is always done along with the meta-analysis, because in a systematic review, we're already pooling all of those studies together. We're just not using their data. Original studies are also called primary research studies. These are research articles that report new and original data collected by authors themselves. So basically, whoever's conducting the research, they're going to use an intervention. They're going to see the outcomes. These are outcomes that are being reported for that particular set of patients for the first time. So these studies involve designing a study, collecting and analyzing the data, and drawing conclusions based on the results. Original studies are designed to evaluate cause and effect relationships. So a cause and effect relationship is the keyword here, or associations between exposures and outcomes. So a high salt intake and hypertension, smoking and lung cancer, air pollution and asthma. So an original study would study the association between the exposure and the outcome. So air pollution and asthma, or smoking and lung cancer. Examples of original studies are randomized control trials, non-randomized. Examples include but are not limited to. So there could be more than these. So randomized control trials, non-randomized control trials, cohort studies, case control studies, cross-sectional studies, etc. So there's two types of original studies: single-arm studies and double-arm or two-arm studies. A single-arm studies only has one group receiving the same exposure or intervention, while two-arm studies, self-explanatory, they have two or more groups. So one group is exposed to the intervention and the other one is not exposed. So they're unexposed, or they're exposed to a different exposure or intervention. The single arm studies, for example, we have 50 patients that are receiving, all of them are receiving drug A, and they're being monitored for side effects. So there's no control. This is a single arm studies. So single arm studies, examples include cross sectionals. There's no follow up, and these are often used to find prevalence. And single arm registries, there is follow up in single arm registries, but again, there's no comparison. Okay. And then two arm studies have basically, they have two groups. One is exposed to the intervention, one is not exposed to the intervention. So smokers versus non-smokers are followed for heart disease, or drug A versus placebo in an RCT. Examples include cohort studies, case control studies, randomized control trials. All of these have two groups basically. So cohort studies have groups which are divided on the basis of exposure, and then case control studies have groups which are divided on the basis of outcome. Randomized control trials have groups that are divided on the basis of intervention and control. So statistical significance. This is shown by p-value. This determines whether your results are statistically meaningful or simply occurred by chance. So this is assessed using the p-value from statistical tests. You don't have to calculate this. The software does this for you. So a p-value less than 0.05 indicates that the results are statistically significant. So when you've extracted data from your studies and you're going to input them into the software, I keep saying software. There's different types of software. You could use RevMan, you could use Open Meta Analyst, you could use Meta Excel, different kinds. We're going to use RevMan because it's the most beginner friendly. So you're going to enter data into RevMan, and RevMan is going to analyze that data and it's going to provide you with a p-value. So you're going to read that p-value and you're going to check if it's greater than 0.05 or lesser than that. So if it's lesser than 0.05, that means that the outcome is statistically significant, and it's unlikely that this outcome was due to chance. But if it's greater than 0.05, so that suggests that the results are not statistically significant and are probably a matter of chance. They may be due to random variations. So you need to remember that less than 0.05 is significant, more than 0.05 is non-significant. Then there's another term that you need to know related to original studies, that is the 95% confidence interval. This is also known as the error range. This basically tells us how generalizable our results are to the relevant population. So basically how well your results, because you're only conducting your research or your study on a particular set of patients, right? Those results might not necessarily apply to the entire population. So the chances that your results, the results of your study, apply to the general population or the broader population is the 95% confidence interval. To put simply put, it just means that if you repeated the same study 100 times, the real answer, the outcome that you got, falls within a range in about 95% of the times. So you're conducting that study 100 times, 95% of the times you're getting the same answers. A narrower 95% confident interval means that your outcome is more precise and your results are more dependable, while a broader confidence interval means basically associates to unreliability. And confidence intervals tend to be narrower in larger studies, because in larger studies you have a bigger population. So the chances of your outcome being due to chance is very low. So there is a narrower confidence interval, which means that the data is a lot more reliable. Okay, results of original studies are reported in one of two ways. These could be reported as raw data or as effect sizes. Raw data, as the name explains, is basically unprocessed information. You just you observed what the outcomes were and you reported them as is. You did not process them. You did not use any formulas on them. No mathematical operations performed on them. You just took numbers and you reported numbers as is. So basically, in a clinical trial comparing drug A to placebo for headaches, 30 people out of 50, out of the total of 50 in the drug group got better, and 10 in the placebo group got better. So this is just raw data. You just reported the outcomes as you saw them, without any statistical calculations. Effect sizes tell us, basically these are when the data is processed. So these tell us how big the difference is between the two groups, like treatment versus placebo or exposure versus control. So it turns raw data into a single number that you can look at and you can tell whether you can look at that number and you can compare that number across different studies to see whether it's whether the intervention group showed better results or the control group showed better results. So effect sizes are different for continuous outcomes and for dichotomous outcomes. So for continuous outcomes, effect sizes are reported as mean difference and standard mean difference. Mean difference is also known as weighted mean difference, WMD. And you need to know this because in multiple studies I've seen they don't write WMD, they just write MD. And on RevMen, it's given as MD as well. And in certain studies, they'll write WMD and then you'll get confused as to what that is. So WMD, the weighted mean difference or the mean difference, is basically the difference between the average value or the mean values in the two groups. You don't need to get into the nook and crannies of this. You just need to know the basic idea. And then the standardized mean difference is used when the studies measure the same outcome in different ways or on different scales. So different pain score tools and stuff like that. So there's two types of effect sizes for continuous outcomes: the weighted mean difference or the mean difference, and the standardized mean difference. The effect sizes for dichotomous outcomes, these are important. These could be risk ratios, odd ratios, and hazard ratios. So risk ratios, what is a risk? Basically, risk is the number of patients with a certain outcome compared to the total number of patients that were in our study. And then risk ratio is a ratio of risk in exposed group and control group. Let me explain. So for example, we had 100 patients and 20 of them improved with drug A and 10 of them improved with placebo, right? So the ratio, we had a total of 100 patients. So the risk of no improvement is, if 20 of them improved, obviously 80 of them did not improve, right? So there's a risk of 80 upon 100 of the patient not improving. And then if 10 in the placebo group improved, but 90 of them did not improve, 90 upon 100 is the risk of the patients not improving in the placebo group. So that's what risk is. And then you can compare the risks in the exposed group and control group, and that is the risk ratio. This ratio, this is what matters. So ratio of 1 means that there is no difference between the groups. So there is an equal risk in both groups, regardless of whether you're giving an intervention or a placebo. And ratio of greater than 1 means obviously the numerator is greater. So like the risk in the exposed group is greater, right? So this risk isn't exactly always for harmful outcomes. This could be for better, like good outcomes as well. This could be for improvement. So a ratio of greater than 1 means that the incidence of the outcome is more in the exposure group, and a ratio of less than 1 means the outcome incidence is greater in the control group. This is self-explanatory basic math. If a ratio is greater than 1, this means that the numerator is greater, and if a ratio is less than 1, this means that the denominator is greater. So risk ratio compares the probability or a risk of an event happening in the treatment group versus the control group. So example, out of 100 patients, 20 improved with drug A and 10 improved with placebo. Am I audible?
Yes.
Yes.
Yes, doctor.
Yes.
Yes.
Okay, if any of you have any questions, please let me know. I will stop in 3 minutes to cater to any questions, and then we can get back to the PPT. Okay, so risk, or let's just complete the effect sizes and then I'll stop for questions. So 20 improve with drug A and 10 improve with placebo. So the risk ratio, because we're calculating risk ratio for the improvement, right? So the risk for improvement in the exposure group is 20. The risk for improvement in the placebo group is 10. According to this formula, we have to divide the risk in exposed group upon the control group. So 20 by 10, 20 divided by 10 is 2. What? No, hold on. What is this? There's been some kind of a mistake. I did something wrong. You get the point, right? This is incorrect. Please ignore this. This is not the risk ratio. Okay. So nahi, haan, theek hai. This is okay. Because 20 out of the 100 patients. So the risk for improvement in the group with drug A is 20 upon 100, because risk is patients with outcome. There's 20 people with improvement. The outcome is with improvement. There's 20 people with improvement, and the total number of patients is 100. And then the same for the placebo group is 10 with the outcome, 10 with improvement divided by 100. And we have to divide these two. So 20 upon 100 divided by 10 upon 100. So that's how we get to. Okay, this is correct. How do we interpret this risk ratio? Basically, we did say that a ratio of greater than one means that the outcome incidence is more in the exposed group. So there is a greater chance. There's a it is 2 times more likely that the patients that are in the intervention group, the drug A group, are likely to improve. 2 times more likely to improve compared to those in the placebo group. So risk ratios often have a 95% confidence interval written in brackets in front of them. When you're going to look at studies, you're going to see that risk ratios are often reported alongside the 95% confidence interval. What is that all about? This is basically, we spoke about 95% confidence interval. It basically tells us how generalizable our results are to the general population, the broader population. So basically, we're saying that this risk ratio that we're reporting, we're 95% confident that the true risk ratio lies within this range. So the one very important thing that you need to know is that if the 95% confidence interval crosses the 1 line on the forest plot, this means that the finding is insignificant or non-significant. Let me show you what this means. In this forest plot, we see that these different lines are for different studies. This line is the confidence interval, and the block in between is the odds ratio or the effect size, basically. This could be odds ratio, risk ratio, or hazard ratio. So if this line, the 95% confidence, because this is a maximized view, you can look at this. The line is the 95% confidence interval. The block in between is the odds ratio or the risk ratio or the hazard ratio, basically the effect size. So if this line crosses this line at 1, there's a line, this vertical line, it's called a line of what is this called? Oh my God. If the 95% confidence interval horizontal line crosses this line at 1, this means that the results reported by the study are not significant. So if you look at these studies, all of these studies, the first study does not cross the line at 1. The line of no interval. This line is called the line of no interval. The first study, the line does not cross the line of no interval. So this study's results are significant and they're reliable. For the second study, we can see that the line is crossing the line of no interval. So this means that the results reported by this study are not significant. For the third one, it's the same. These are not significant because these are crossing the line of no interval. And then the fourth one, the same. The fifth one is not crossing the line, so those results are significant. You get the point, right? We will get back to this, so in case anyone is confused, please wait. Okay, so keep this in mind. This is a very important point. If the 95% confidence interval crosses 1, this means that the finding is insignificant or non-significant. Odds ratio is very similar to risk ratio. It's calculated in a slightly different manner. This can also suggest direction, but it is based on odds, not risk. So when the event is common, we prefer to use odds ratio. If both are given by a study, if a study reports both odd ratios and risk ratios, we're going to prefer risk ratios. We're going to use risk ratios instead of odd ratios. So risk ratios or odd ratios, if a study, there's no compulsion to use one or the other. You're not bound to use one or the other. You can use any that you prefer, but generally we prefer to use risk ratios, except in cases of case control, because in case control, you have to use you're required to use odds ratios, not risk ratios, without any exceptions. So for any other kind of study, you could choose whether you want to use risk ratios or odd ratios. Generally, people prefer risk ratios, but for case controls, you're obliged to use odds ratios. And the third kind of effect size for dichotomous dichotomous outcomes is hazard ratios. This is also similar to risk ratios and odds ratios, but this is not restricted by time. So you can pool studies. One of those studies could have a follow-up time of 3 years, and the other could have a follow-up time of 1 month, and you could pool them together. It doesn't matter. If they're reporting hazard ratios, you can pool those hazard ratios. So if also this shows whether the event rate over time is higher in the intervention or the control group. So if a hazard ratio is less than 1, this means that the event is slower in the intervention group, because the intervention is obviously in the numerator. And if the hazard ratio is greater than 1, this means that the event is happening more often or faster in the intervention group. So for example, if you're looking at smoking and heart attacks, for example, we will see that patients who are smokers, they will have a faster recurrence and a more incidence and a greater incidence of heart attacks. So their hazard ratio will be greater than 1. Okay. Hazard ratios and risk ratios can be pooled together. However, odd ratios cannot be pooled with any other effect size. Effect size is basically risk ratios, odd ratios, and hazard ratios, as we discussed. You can pool hazard ratios and risk ratios, but you cannot pool odds ratios with any other kinds of effect size. So this is also another important point. Two very important points that we mentioned, I've highlighted. One is this one: if the 95% confidence interval line crosses the line of no interval, this means that the findings are insignificant, and if and that we cannot pool odds ratios with any other kinds of effect size, but we can pool hazard ratios and risk ratios. So basically, if we're looking at an outcome, for example, we're looking at heart attack, the incidence of heart attack in smokers versus non-smokers. We have a total of 10 studies. 6 of them could be reporting risk ratios, 4 of them could be reporting hazard ratios. We can pool all of these studies together for the same outcome. But if 6 of them are reporting risk ratios, 3 of them are reporting hazard ratios, and 1 of them are reporting odd ratios, we can pool the risk ratios and hazard ratios. So we can pool the data from 9 studies together, but we cannot pool the data from the study that is reporting odds ratios. This is a forest plot. You need to know how to read a forest plot. So a forest plot is the most important figure of a meta-analysis. They display the effect sizes, which we just spoke about, and the 95% confidence intervals of each study and the pooled effect of them. So each outcome has a different forest plot. So if you're looking at maybe 3, 4, 5 different outcomes, you'll have 3, 4, 5 different forest plots in your meta-analysis. So this is what a forest plot looks like. This is what the forest plot in different softwares have different kinds of forest plot. They're the same kind, they just look a bit different. So this is what the forest plot that we're going to get after RevMan. Analyzing the data in RevMan, this is what we're going to get. So this is another forest plot. This is a bigger picture, so we're going to explain it over here. So this is the effect size. This shows odds ratio. This could be risk ratio, hazard ratio, depending on what effect size you used. The model could be fixed and or random effects model. We're going to discuss models tomorrow when we're going to do analysis. And then 95% confidence intervals. The whole line, as I explained earlier, this entire line is the 95% confidence interval line. And right in the middle of this line is our effect size. And this diamond is the overall result that we're getting. The width of the diamond is the overall 95% confidence interval, because we're pooling data from 1, 2, 3, 4, 5, 6, 7, 8 different studies, right? Each different study has a different line of confidence interval and odds ratio. But the overall outcome that we're getting after pooling all of these 8 studies, that is what this diamond shows. So the width of this diamond is the overall 95% confidence interval for this outcome, as reported by all the studies pooled together. And the where it lies on the y-axis is the overall odds ratio. So this is what a forest plot is. this is what a forest plot looks like after you've analyzed it on Revman. So this has 3 studies. So the study or subgroup analysis will do that tomorrow. But there's three studies: Shotara et al., Fuchs et al., and Shung et al. Please, I apologize if I'm butchering these names. Pembrolizumab is basically the exposure, the intervention. Control is placebo. Risk ratio. In the previous slide, we used odds ratio as the effect size or effect measure. Here we're using risk ratio. And we're using a random effects model, 95% confidence interval. It says random, which is the random effects model, comma, 95% confidence interval. So the value outside of the brackets is what our risk ratio is, and the value within the brackets is what our 95% confidence interval is. And then this is our forest plot. And the total events for heterogeneity and the test for overall effect, this is our overall result that we're going to discuss in our results section in the manuscript. The second step, now we're done with the main part. The second step is systematic search. Systematic reviews and meta-analysis are conducted as per the PRISMA guidelines. According to these guidelines, the search must be done in at least 2 databases. PRISMA guidelines is basically a set of guidelines that we have to abide by. We have to conduct our entire meta-analysis according to these guidelines. Otherwise, it's not going to get published. These are a set of rules that we have to abide by. And according to these guidelines, the systematic search, which is basically the literature search that we're doing, when we go onto the databases, when we have a research question, we go onto the databases and we search for all the studies that have been conducted on that topic. That is what a systematic search is. So basically, this systematic search must be done in at least 2 databases by 2 people independently. So 2 separate people have to independently search at least 2 databases. And then they're going to check if they have enough studies, if there has been a meta-analysis already published on it, if the topic is viable, if it's feasible. This is what this slide is all about. Literature search is a comprehensive search. When we're doing a literature search, we basically come up with a comprehensive search strategy. We formulate that, and then the databases are searched with that search strategy. So relevant articles are then shortlisted, and the literature search is conducted on at least 2 databases by at least 2 independent researchers. Databases that we can use include PubMed, which is free, Cochrane, which is free, clinicaltrials.gov, which is also free, Google Scholar, also free. Embase and Scopus are both paid. I'm going to teach you PubMed and Cochrane. Clinicaltrials.gov is very simple. If anyone wants to learn, I will teach this one to you tomorrow. And Google Scholar is basically the same thing that the same search string that you're going to use in PubMed. You can use that on Google Scholar, and it's going to give you a lot of results. Screening of studies. This is the process. So now we have a set. Now we have like 5 to 10 studies that we know that we can use in our meta-analysis. These 5 to 10 studies that we've shortlisted after screening those studies. When we first search the databases, we will come up with like multiples of outcomes. Like if you put the search strategy into the search bar on PubMed, and it's a popular topic, you're going to get over 1,000 results. And you're going to have to screen through all of the studies, and you're going to have to shortlist the studies that you can include in your meta-analysis. So there's different levels of screening. First, there's primary screening, and then there's secondary screening. In primary screening, you're going to only look at the title and abstract of the studies that showed up on your initial search on PubMed. That alone is going to help you in shortlisting at least 50 to 60% of the studies that showed up. Because if there's thousands of studies, you're not going to be able to include all of them. Most of them are not going to match the PICO. So you're initially going to just look at the title and abstract, and then you're going to see if they match your PICO. If they do match your PICO, then you're going to read the full length of the study, and then you're going to confirm if they match your PICO. After this, you're going to be left with 4 or 5 randomized control trials, or if you're doing all the observational studies, maybe 30, 40, 90, but not more than that. So there's different tools that help us with screening of the studies. We can use EndNote, Ryan, and Zotero. I'm going to teach you Ryan today. So a tip is if you're updating a meta-analysis, which means that if a meta-analysis has previously been published on that topic and you found new articles that you can add to that meta-analysis and you're updating that meta-analysis, you can basically use the studies in that meta-analysis. For example, this meta-analysis was published in 2015, right? And it has like 8 studies. you don't need to go and search from the inception of PubMed. You can only start from 2015, because you know that this person who published the previous meta-analysis already searched the databases from the inception of the database up until 2015. So now I will use those studies, and from 2015 onwards to 2025, I'm going to search the database and look for studies. So basically, if a previous SRMA has been published, for example, in 2015, just take the older articles from there and conduct your literature search from 2015 onwards. So now we have to build a search strategy. I spoke about search strategy just now. This is basically the words, the string of words that you're going to use, that you're going to enter into the search bar of your database. So you use Boolean operators in building a search strategy. There's 3 different kinds of Boolean operators: and, or, and not. You use and to retrieve records containing 2 terms or more than 2 terms. So basically smoking and teenagers. Or when you use or when you want similar, when you're using synonyms. So basically there's different words for teenagers. So you could use teens or youth or adolescents and so on. You use not when you're trying to exclude a certain something component from your search strategy. So for example, I want to conduct a study, but I don't want people from Asia in that study. So I'm going to write not Asia, or not Africa, or not Europe. So this is fairly basic. Boolean operators are used in caps. Always use caps when using Boolean operators. And you have to use brackets. For example, how do we find articles that study the health effect of smoking in teenagers? You write smoking and teenagers. How do you find articles that study the teenage age group? You search for teens or youth. So now I have an exercise for you. Make a search strategy using this PICO. So the population is elderly patients, age 65 plus. You don't need to use the 65 plus. The intervention is physical therapy. The control is no physical therapy, and the outcome is improvement in mobility and quality of life. Please make a search strategy and send it on the chat box. You have 3 minutes. Okay, we have answers. This is the answer, and a lot of you got it right. So kudos to you. Very nice. Uh, Moving forward, do you want me to explain this? I think it's pretty self-explanatory. Elderly patients, you can use different words for this. Elderly patients or older patients. And then we have physical therapy or rehabilitation or exercise therapy. Am I audible? Okay, I am.
Yes, you are. Yes, yes, we can hear you.
Yes, but the mic is muting sometimes.
Okay, sorry. Okay, so for elderly patients, we can use elderly patients or older adults. For physical therapy, we can use physical therapy or rehabilitation or exercise therapy. And for no physical therapy, we can use no physical therapy basically, or no intervention. And for improvement in mobility and quality of life, we can use mobility or physical function or quality of life. So, however, this was very simplified, okay? But we need to have a detailed search strategy, which we need to provide in tabular form when we're sending our study for publications. So this is the table from one of my studies. So you use different databases. For each database, you have to mention the search strategy that you use on that database and how many results it yielded. So basically, I used this search strategy on PubMed, and the results were 1,452 results. So quotation marks are optional. You could use them. You could also not use them. Mesh terms I will explain to you, and all fields I will explain to you later in this presentation. So I will demonstrate towards the end of this lecture the use of PubMed and Cochrane to search for articles and for authors. So the process that you go through when you screen for the articles, when you search for the articles, then you screen them and you shortlist them, you need to concisely and briefly summarize that into a chart, which is called the Prisma chart. The Prisma chart is standardized. You just need to fill in the numbers. So basically, the number of records identified through database searching, n equals to this space will be blank. You have to fill it in with the number of records that you identified initially on the database searcher. And then the records after the duplicates are removed. Obviously, there's duplicates. I will teach you how to use Ryan. The results that are yielded on the database searching initially, after the very first search, you're going to upload all of those studies onto Ryan AI, and Ryan has an option where you can automatically remove all the duplicates. So after the duplicates are removed, you're left with a obviously lower number of studies. So you're going to write that in this blank space, and so on. So this Prisma chart is standardized. You just need to fill in the figures, the numbers. Next, now when you're done with the database, the literature search, you move on to step 3, which is data extraction. Now you have your studies. Now you have your topic. Now you know you're doing a meta-analysis and that this is happening. Now you're going to look at those studies, you're going to open them, you're going to read them, and you're going to extract data from them. Every single outcome that a study reports, you're going to extract the data for it, and you're going to put it into an Excel sheet, and then you're going to use that Excel sheet for your analysis later on. So you need to extract data, and outcomes that are reported by at least 3 studies are included. Obviously, as I said before, you need at least 3 studies to conduct a meta-analysis. So if an outcome is being reported by at least 3 studies, then you're going to include it. If not, it's going to be too weak of an outcome, and there's going to be too high of a chance of the outcome being a matter of chance. So data extractions, once the studies are finalized, the next step is to extract the data from the included studies. This is mostly done on Google Sheets or Microsoft Excel. The data extracted is of 2 kinds. One is for the baseline table. These are the patient and study characteristics at the beginning of the study. So basically, if you're using a randomized control trial, before the randomized control trial started, you're going to the researchers who were conducting that randomized control trial, they actually noted down the patient. They noted down and they published the patient and study characteristics. For example, the mean age of all the patients that were included. For example, their comorbids, any history of heart attacks, any history of stroke. So basically anything pertinent to that, to the research, they recorded and they published. So you're going to have to extract that data, and you're going to put it into a table on Excel, and that is going to be your baseline table. And a baseline table is published in your manuscript. And then there's the outcome data. This is data for different outcomes that the studies were reporting. This will not be published in your manuscript, but this is the most important one, because this is the data that you're going to use for analysis. And you have to make sure that there is absolutely no error while extracting data for either the baseline table or the data extracted for the analysis. This is what the baseline table looks like. These are the patient and study characteristics. You can see you have to write the name of the study and the year it was published, the type of study, randomized open label phase 3 trial, and then the number of patients in each group. There's an intervention group and a control group in each study. So for Shung et al., there were 47 patients in the pembro group and 47 in the placebo group, and so on. Then the median age, the male to female ratio. Sometimes some studies only report the number of males, some report only the number of females, because they're being those studies are being conducted on that specific gender. So we're going to extract what the study is giving us. The type of cancer. Basically, these are all the baseline characteristics that the study reported before they started any observation or any intervention. Before anything, they recorded the baseline demographics and details, and we're going to have to extract that and publish that as it is. This fourth step is to assess the quality of the studies that we're including in our meta-analysis. Because as I mentioned previously early on in the meeting, some studies are not that high quality. There are certain age groups that are missing, for example, in those studies, or they're missing a certain gender, or they're missing a certain group of population with a certain comorbid, and they're not including that specific population in their study. And that is a con. That is not a good trait for a study. A study should be all inclusive. So if any study is excluding any part of it for any reason, it could be a valid reason, we're going to have to mention that in our meta-analysis, and we're going to assess the quality of that of all the studies that we're including, and we're going to account for the low quality of any studies that are basically low quality. So we do a quality assessment of the studies in a meta-analysis to evaluate the risk of bias and credibility of the evidence. Basically, we're trying to see if the studies we are including are good quality. If they are good quality, that means that they have a low risk of bias. Quality assessment is only done in two-arm studies, because the standard tools that are used for quality assessment, they are designed for two-arm studies, and also to keep things straightforward. What are the standard tools designed for quality assessment? For randomized control trials, we use ROB 2.0, risk of bias 2.0. Software for non-randomized control trials, we use Robbins 1. For observational studies, we use Newcastle-Ottawa scale. These are all very simple, very easy to use. There's a certain instruction manual kind of thing. You read that, you read the methods and the results of each study that you're including in your meta-analysis, and you're going to grade the study on a scale. The scale is going to be given to us by the tool. For example, ROB 2 has an entire instruction manual, and it's going to tell us to mark a certain grade if a study has a certain characteristic. So we're going to read the study, its methods and results, and we're going to check if that certain characteristic is present in that study or not. So we'll get a final assessment of what the quality of the study is, and then after we've done a quality assessment of all the included studies, we're going to analyze that in our management. Another important point is that quality analysis for the quality assessment for studies in the older meta remains the same. We just need to assess the quality of the newer studies that are being added to the updated meta. Step 5 is analysis. This is the fun part. This is for conducting a meta-analysis. We utilize softwares like RevMan, Comprehensive Meta-Analysis, Meta Excel, Open Meta-Analyst, and R. R requires coding. It's a bit complicated. Step 6 is manuscript writing. We now have analyzed our data. We have everything. Now we just need to put everything into words so that whoever is reading our meta-analysis can just read the manuscript, and they can get a general idea of what we're trying to prove in our meta-analysis, what the objective of our meta-analysis is. So there's parts of a manuscript. These are all compulsory. They cannot be, none of these can be omitted. So you have to have, the first part has to be the abstract. Then we have the introduction, the methodology, the results, the discussion, and the conclusion. We're going to teach you how to write all of these on day 3 of our workshop. Once you're done with the manuscript, you're done with the meta-analysis. Now you just need to submit it. The publication pathway is you conducted a research, you wrote your findings in the manuscript, you submitted it to a journal. Then the journal, once you've submitted it to the journal, there's an editorial review followed by a peer review, and then after the peer review, the journal will either accept your manuscript, they either reject it, or they'll ask you to revise the manuscript. They'll ask you to make certain edits in the manuscript. Revisions, the most likely results is that you will get edits on your manuscript. You'll have to edit your manuscript in certain ways. In case you do get revisions on your manuscript and you have to make edits, there's a thing called a rebuttal file. A rebuttal file is basically when the manuscript, when the journal gets back to you after your initial submission, they're going to tell you what changes need to be made. And these are going to be numbered changes. So like, for example, they need you to make 3 changes in certain areas of your manuscript. For each, you're going to make the changes and then you're going to make a rebuttal file. And you're going to go number 1, the comment from the author, from the editor, and then you're going to address that comment. You're going to tell them, I made these changes in line number this to this, and you were correct, and these changes have been made. And you're going to, and if no changes are being made, you're going to have to justify why those changes are not being made. So that's what a rebuttal file is. A rebuttal file is then submitted with the edited manuscript, the revised manuscript. So you have to find a suitable journal. You have to adjust the manuscript according to the journal's guidelines, and then you have to submit it. Every journal has certain guidelines. Some manuscripts want the tables and figures to be in the same file as the general text. Some want them to be different files. Some want different journals have different preferences. Suitable journals, there's journal finders. There's an Elsevier journal finder, a Springer journal finder. I'm going to show you all of those. You can just enter your abstract. You're going to input your abstract into the journal finder, and it's going to suggest different journals that are suitable to your abstract and your to your research. Journal selection, there's 3 different kinds of journals. There's a top tier journals, a middle tier journal, there's middle tier journals, and there's lower tier journals. The top tier journals are New England Journal of Medicine, Lancet, JAMA, European Heart Journal. These are all high impact factor journals. Middle tier journals include American Journal of Medicine, the American Journal of Cardiology, and lower tier journals include Curious and Medtivo. These are fairly new, and hence they're low tiers. What is a journal's impact factor? An impact factor is a measure of the number of times an average paper in a journal is cited during a year. So higher the impact factor, the more the number of citations of that article. So if you're publishing in a very high tier journal with a great impact factor, with a very high impact factor, this means this guarantees more number of citations. But when you're starting out, you should prefer to submit your manuscripts to middle tier or lower tier journals, because almost always the higher tier journals, top tier journals, are going to reject manuscripts from beginner level writers. When deciding the perfect journal for your paper, this metric is an excellent tool to guide you through the process, obviously. Then there's another kind of metric that we use to describe journals, that is Q1, Q2, Q3, Q4. Q1, these are the top 25% journals in the world. These are the most prestigious, the most highly cited. Q2 is the next 25%. These are also well reputed, well respected. They have good impact. The middle 25% are also solid and reputable, and the bottom 25% have a lower impact, and they're newer or less established journals. Then there's certain ethics when you're conducting research. You have to be honest, you have to be objective, you have to have integrity, you have to be very careful to avoid errors. You have to be open, you have to share the findings and accept criticism. And criticism, this is something that you're all going to deal with in your research journals. Transparency, accountability, intellectual property, confidentiality. Most journals require you to not share your manuscripts before they have been published in that journal. After accepting your research, they're going to ask you to keep your research confidential until it has been published by the journal. So responsible publication, respect for colleagues, social responsibility, non-discrimination, competence, and legality. Follow laws and institutional policies, obviously. The IC, this is the website that you can visit to read about research ethics. Authorship. The authorship is the most important thing. This is what most people ask me about when conducting meta-analysis. Authorship, the obvious thing to know is that the more you contribute towards the project, the higher your authorship position will be, obviously. But there's a certain set of guidelines called the ICJME guidelines that dictate what a person's authorship, what a researcher's authorship position is going to be. There's a criteria. It's called the ICJME criteria. It requires all authors to contribute substantially towards the work and to draft or revise the work, approve the final version, and be accountable for accuracy and integrity. All the listed authors must meet these criteria. Author responsibilities, non-author contributions, AI in research. This is very unimportant. Let's read about AI in research. This is very important. You can use AI in research, but you can not. You have to disclose this. If you're using ChatGPT for your research, for your manuscript writing, for anything, you have to disclose it within your manuscript. Also, you can't just expect ChatGPT or any other AI tool to do all the work for you. You're just going to give it prompts and it's going to help you. It's not going to do your work for you. So when you're writing a manuscript, you have to write the manuscript yourself. If you're going to use ChatGPT's written version, that's going to be detected. AI detected manuscripts are always rejected, and it's a shame if you're using AI, because at this level we should know that we have to be honest when we're conducting research. So you can take help from AI, but you can't expect AI to do all the work for you. Ghost, gift, and paid authorships are unethical and they should be avoided. These are absolutely unacceptable. You have to contribute towards a project to get authorship in that project. Finally, any questions from this session, then we can move on towards the main part, which is the database searching. Does anyone want me to repeat anything? Does anyone want me to answer any questions? If not, then we can move on to how will we be selecting a topic. To select a topic, this PPT is going to be shared with you. The recording is also going to be shared with you. What I do is, I did include tips in the PPT, but personally what I do is I keep a lookout on my favorite journals, medical journals, journals of my interest, and every time they publish an original article, the same thing that I told you, I go back and I check if the meta-analysis has been conducted on it. Secondly, the FDA website is very, very useful in this. If FDA approves a new drug or a new surgical procedure or anything, that's a very good lead. You can use that and you can conduct a database search and you can see if a meta-analysis can be done on it. Also, clinicaltrials.gov also publishes new trials every day. You can go to clinicaltrials.gov and you can search if what new trials have been published, and you can check if you can do a meta-analysis on them. Yes, all 10 to 11 participants, provided that they contribute towards the project, they're going to get publication. I will share my screen when I teach you guys the database. Let's take a breather. I'm going to open the databases. Let's take a 5-minute break. You can continue to send in your questions. I will answer them. I'm just opening up my databases. Okay, I see that there are no more questions. Oh, there is one question. Can a meta-analysis be self-published or is there a minimum number? There is a minimum number of authorship required. You have to abide by the PRISMA guidelines, and you cannot publish a meta-analysis on your own. If I remember correctly, you have to have at least 6 authors in a meta-analysis. I will recheck this and get back to you tomorrow, but I'm pretty sure it's 6, the minimum number of authors. Okay. So this is how I started off with my topic last year. I didn't start meta-analysis last year. This is just the best topic that I did a meta-analysis on last year. So I was reading through the FDA website and I saw that this is a drug that has been approved, Resdifra, resmetirom. This is a novel drug for the treatment of non-alcoholic steatohepatitis. So prior to this, there was no drug for the treatment of NASH. This was the first drug. So this was obviously a huge thing. I wanted to do a meta-analysis on this. So this is how I got my idea. Now that I've seen this, now I know the intervention is Resdifra. Once you read through the study, FDA only approves drugs and surgical procedures after a trial or two have been published on it, after a trial or two have shown success for that pharmaceutical therapy or surgical intervention. So you will read through this entire thing. I'm pretty sure they mentioned the trial NCD number. Hold on. This. Okay. They did mention that the safety and efficacy of Resdifra was evaluated in a randomized double-blind placebo-controlled trial. So now I knew that there was a trial that studied Resdifra. So I went on to PubMed. So we're going to use 3 databases: PubMed, clinicaltrials.gov, and Cochrane. Once you're done with these 3, you can obviously use the same search string and you can search on Google Scholar. Google Scholar is the one that is 100%. That is the one database that is going to give you the maximum number of results. Most of them are going to be they're not going to be related to your topic. They're just going to match 1 or 2 words of your search string, and you're going to have to read through 15,000 different results that show up. That's a real pain. Now I want you all to open PubMed. First, look at what I'm doing, and then I want you guys to do the same. You go on to PubMed. This is the search bar. You're going to write your search string in this search bar. So my research question was, I have to come up with a PICO. The first step was coming up with a topic. For the topic, we learned about the PICO. So my PICO, the population is patients with fatty liver disease. Now there's different words for fatty liver disease. You could use steatohepatitis, non-alcoholic steatohepatitis, fatty liver disease. You can read through this article or any other article or whatever study, that randomized control trial that you found. You can read through that, and there's going to be different words for the same thing. So you can use those, and you can come up with your search strategy. Give me 1 second. Okay. So if we were to formulate a PICO from this, we know that the population would be patients with fatty liver disease. The intervention would be Resdifra, also known as resmetirom. One of these is a brand name, the other is the generic name. The control would be placebo or whatever, depending on different studies. And the outcome is treatment, or what is the outcome? Hold on. So the outcome is efficacy and safety. And so when we're talking about safety, we're basically talking about adverse effects and stuff like that. And when we're talking about efficacy, we're talking about improvements in the symptoms of that disease. So now that we have a PICO, we're going to form a search string. So our search string, the PICO first we need to include the population. Our population is patients with fatty liver disease. Or I used or in caps. Okay, this is the Boolean operator. Or we could use NASH or non-alcoholic steatohepatitis. This is the P population. And then we move on to the intervention. The intervention is Resdifra. You have to make sure the spellings are correct. Resdifra with a double F. Okay. Resdifra or resmetirom. These are both the same thing, the same drug. Sorry?
They are intervention.
Yes, this is the intervention. So the population is patients with fatty liver disease or NASH or non-alcoholic steatohepatitis. The intervention is Resdifra or resmetirom, as shown by this article. You don't necessarily have to have an article that you're going to refer to. You could have a randomized controlled trial. You could have any other original study. And then you're going to move on to the control. You just want to write control or placebo. And then the outcomes, we don't have any outcomes for this. We're just winging it for now. This is our PICO. Now we're going to search. So we have 40 results because this is a fairly new drug. We obviously don't have a lot of trials for this. There are a number of filters on the left side. You cannot use any of these filters except for the time filter. All the other filters are not accurate at all. You cannot use them. But you can use a filter for the time. So you could use the filter and you could tell the database to give you articles from that were published 1 year and onwards, and then or 5 years and onwards and 10 years and onwards, or a custom range. So however, for the sake of saving time, I am going to use the filter. You can roughly use a filter just to see if your topic is viable and feasible or not. So to see if there are an appropriate number of, that is a minimum of 3 randomized controlled trials or original studies to include in your meta-analysis. But however, when you're doing the full depth screening, you cannot use the filters. So for now, I'm going to use the clinical trial and randomized control trial filter. You can do the same. Initially, you can use the filters to see if there are enough number of studies for you to conduct a meta-analysis. And then when you're doing when you know that you can do a meta-analysis on this and there are a minimum of 3 original studies or randomized control trials, then you can remove those filters and you have to go through all the studies that are showing up. So this is one randomized control trial that showed up. This was another one. This was another one. So different randomized control trials showed up. So this is how you use a search string to look for results. So is this clear?
Yes.
If there's
Yes.
any confusion, please write in the chat box. I will re-explain. If I went too quickly, I can repeat.
Yes, please go over it again. Thank you.
Okay, I will repeat. We first formulated our PICO. PICO stands for Population, Intervention, Control, and Outcome. The population was patients with fatty liver disease. The other words that we can use, because we discussed the use of Boolean operators, right? This we discussed the use of 3 of these Boolean operators, and, or, and not. When we want to look for similar terms, like some studies could use the word fatty liver disease, other would have used the word non-alcoholic steatohepatitis, some other studies would have used steatohepatitis. So we want all of those studies to show up. So we're going to use the or Boolean operator, and we're going to include all of these words. So we wrote fatty liver disease or NASH or non-alcoholic steatohepatitis. This is our population done. Then we moved on to our intervention, PICO intervention. So the intervention was Resdifra or resmetirom, the brand name. So we included that, and Resdifra or resmetirom. This is our intervention done. Next, we move on to our control. Then we wrote and control or placebo, because we don't have a definite control for now. We just know that our intervention is resmetirom and our patient population is steatohepatitis. And we know that there have been trials which have assessed the safety and efficacy of these because the articles told us so. Or if I wasn't using the FDA website, I would have just used these two. So there is obviously, because we are going to conduct a meta-analysis of randomized control trials. Randomized control trials are always two-arm studies. There is always an intervention and always a comparator group, that is a control or placebo group. So I wrote and control or placebo, and then ideally I should have added outcomes, but I don't know what outcomes to expect. So I don't want to confine the database to certain outcomes, because then it would miss out on the other outcomes. So I'm just going to leave out outcomes and just search the database with the population, the intervention, and the control. Then I hit search, and without the filters, it gave me 40 results. Hold on. Here, it gave me 40 results. And I said that during the initial screening, you can use filters. There's filters to the left of your screen. But once you know, you can only use filters when you're trying to figure out if you have the minimum number of studies that are required to do a meta-analysis. So when you're checking the viability and feasibility of your meta-analysis, and when you're checking if you have the minimum number of required studies to conduct a meta-analysis, then you can use filters. However, once you know that this meta-analysis can be conducted, you have to get rid of the filters. The only filter you can use then is the time filter. So that's the only filter then you can use, because otherwise you're going to miss studies. If you use any other kind of filter other than the time filter, they're inaccurate. You could miss a very important study. You don't want to use that. You are required by the PRISMA guidelines to include every single study original study that has been conducted on that topic to date. So you don't want to take any chances. So you're not going to use any filters. But initially you can use filters to check if the meta-analysis is even possible. So for my initial search, I used these two filters, clinical trial and randomized control trials, because I am trying to conduct a meta-analysis of randomized control trials. So that is what I did. I have 8 results. Most of these are randomized control trials. So now I know that a meta-analysis can be conducted on this topic. So that is one database done, PubMed done. This is the most widely used database. The other database that we're going to be using is the Cochrane database. For the Cochrane database, you just type Cochrane on your Google search bar. The first website that shows up is the Cochrane database. In the Cochrane database, you go onto Cochrane library. So once I opened that website, I went to Cochrane library and clicked on that. Clicking on that redirected me to this page. On this page, on the right upper part of the screen, you have this option that says advanced search. You're going to click on advanced search. I'm going to wait now so that you can all open up Cochrane and arrive on this screen. So you write Cochrane on your Google search bar. The first website that shows up, you're going to click on that. On that website, you're going to click on Cochrane library, and that is going to redirect you to this page. This one. And on this page, you're going to click on advanced search. Please send a thumbs up or a message on the chat box once you're on this page. Okay. Once you're on this page, you're going to click on Search Manager. This is our destination. This is where we're going to search our search string. So this is what shows up. In the first line, you're going to write your, so there's different lines that are going to show up. Once you fill in this bar, you're going to click on the next line and you're going to get another bar. So you need at least 4 bars. So for PICO, so for 1 bar for the population, the other for the intervention, the other, and then another one for the control, and the last one for the outcome. And then another additional one, which I'm going to show you what that one is for. So the same search string, we are going to use the same one, but the population is this, right? Our target population was people with patients with fatty liver disease or NASH or non-alcoholic steatohepatitis. We're going to write this exact same thing in the first line, the population. So fatty liver disease or CAPS or NASH or non-alcoholic steatohepatitis. That is our first line, the population. Then we're going to click continue. The second line is our intervention. The same thing we're going to use for our intervention. We don't need to write and, because when we were directed to our second line, we already had and. So this, if you, sorry, once you're on your next line, you use this. Now you're going on the second line, you're going to use intervention. You're going to write your intervention, which is resdifra or resmetirom. Next is our control. So we're going to write control or placebo. The exact same thing as we did in PubMed. Oh, I forgot brackets. Continue. For each line, there's a number in front of it. This is the number of results that are being yielded by only that line. So when the database searched for fatty liver disease or NASH or non-alcoholic steatohepatitis, it yielded 7,772 results. When it searched resdifra or resmetirom only, it yielded 77 results. And when it searched control or placebo, it yielded, I don't even know how to pronounce that. The last line, we did not specify any outcomes, so we're going to skip that. So the last line, this should have been, ideally this should have been the outcomes, but we're not using any outcomes for now. So the last line, no matter what the case, whether you use the outcome or not, if you're using all 4 of the components of PICO, PICO, then there's going to be a 5th line. But since in this case we're only using PIC, the 4th line is going to be the final one. This is where we're going to put the ands. So the first is PICO. So we use #1. Sorry. #1, which is the first line. So basically the population, and #2, which is the intervention, and #3, which is the control. This is our final search string, this #1, #2, #3. And this is exactly how you're going to write it in the table in your manuscript. As I said, you're going to have to present your detailed search strategy in a tabular form. This is for PubMed, but for Cochrane, you will do the same. You'll write #1 and then whatever you wrote for the first bar, and then #2 and whatever you wrote for the second bar, #3 for whatever you wrote for the third one. And the last line is going to be you combining all of those preceding hashtags, so the preceding lines, and you're going to put them into one single search string. And the final number of results, you're going to click on that number. So the final search string, the number in front of it, you're going to click on that, and this is your final results. This is what you're going to screen through. Again, there's different filters here. The filters on Cochrane are a lot more accurate, but even these are not 100% accurate except for the time filters. So we know that there's three articles that have been published in 2025, 19 in 2024, 13 in 2023, 14 in 2022, and 6 in 2021. There's a total of 65 trials. If there were any Cochrane reviews, systematic reviews, or narrative reviews, they would have showed up over here. But there's 0 Cochrane reviews, 0 Cochrane protocols, 0 editorials, 0 special collections, and 0 clinical answers. All of the results are clinical trials. But they can't all be included in our meta-analysis. We have to filter through these. Also, when we're looking at studies, and I'm going to explain this tomorrow, when you're looking at different studies, you're going to you're going to have results which are going to be original studies, but there can be several studies that are going to be conducted on the same population. So basically, one researcher used the same intervention and the same control, but he studied different outcomes in both of his studies. So the population was same, the interventions were same, the control was same. But in both studies, he was studying different outcomes. You cannot use both of these studies because it's the same patient population. This is a bias. You can't use the same population twice. So you're going to have to look at the author and the NCT number. So when a trial is conducted, it is registered onto clinicaltrials.gov or whatever trial registry the country follows. For example, for Japan, it's different. For China, it's different. For US, it's the clinicaltrials.gov. Every clinical trial that is conducted is registered on clinicaltrial.gov. And once it's registered, the researcher gets an NCT number. So you need to compare NCT numbers. If any two studies have the same NCT number, it means that the patient population is the same, and only one of those two or three or however many studies can be included. So only one study of the same NCT number can be included in a meta-analysis. Is that clear? That was way too confusing.
Absolutely.
Okay. So these are the results. So now we know that we had 40 results that showed up on PubMed and 65 that showed up on Cochrane. Now we're going to look at clinicaltrials.gov. That is not how you spell that. The first website that pops up, we're going to click on that. This is what shows up. This is how you're going to search. This is fairly straightforward. The condition or disease, we're just going to write non-alcoholic steatohepatitis, non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Other terms, you can include all those terms that we used in our search strategy. I'm not doing that because for the sake of saving time. Intervention is Resdifra, or rather Resdifra. You don't specify the location and you use all studies. The study status is all studies. Then you're going to search. It's going to give you all the registered trials which use Resdifra as an intervention. Oh, Resdifra is the brand name, Resmetirom. Resdifra is the brand name. Don't use brand names, use the generic name. This is what shows up. You have how many results? You have 4 studies that are registered on the clinicaltrials.gov. So you look at them and you see if they have been completed or not, and you're going to include them. Some of them are still recruiting. Obviously, they don't have results yet, so we can't include those. So this is how we search different databases. A few more things before we end this. You can search for different, the way you search for authors on PubMed. Once you publish your studies on a PubMed cited in a PubMed cited journal, you can search your name on the PubMed search bar and your study will show up. Or you can search for any researcher's name on PubMed and it will show up. For example, let's look at this study. So the first author of this study is Stephen A. Harrison. How am I going to search this on the database? So the database uses your last name first, and the other names, your middle name and your first name, are only the initials of your first name and middle name are used. So Harrison SA is how I will search it on PubMed. So I'll write, oh look, Harrison SA. See, the name was Stephen A. Harrison, right? So the last name is used fully, but the for the first name and the middle name, only the initials are used. So that's how you search the database for authors. Now that we have our studies, we've done our preliminary search. how are we going to screen through this? We can't just individually open studies on this on PubMed and read them and see if they're viable or not, if they can be included or not. No, what we're going to do is we're going to compile all of these and we're going to send them to a screening tool. It's a software called Rayan.ai. You can search it up. It's called Rayan AI. You open this link, the first thing that shows up. And you're going to log in. Or if you don't have an account, you're going to make an account first. You're going to sign up over here. But I do have an account, so I'm going to share that. Once you log into Rayan.ai or sign up, you're going to get this interface. This interface opens up. In the top left corner, now you're going to upload your review here, all of your studies here, and then you're going to invite different members to screen. Because if you have 1,000 plus studies that showed up after your preliminary search, it's humanly impossible for you to sit there and you're going to have deadlines to do the screening and come up with studies to include. You're not going to sit there for 5 days and read through the studies. You're going to have multiple members working on it, right? So what you can do is you can upload all 1,000 of those studies that you got from PubMed. I'm going to show you how to upload them onto Rayan.ai. You're going to use all of them, upload them onto Rayan.ai. You're going to invite members of your group, people you're working with, and you're going to divide those studies. So basically, this has an option to, first, you're going to remove the duplicates. Out of those 1,000, at least, let's say, for example, 200 of them were duplicates. Now the duplicates have been removed and you're left with 800 studies. You can then invite, for example, 4 students, and each of you can do 200 studies, and you can just very quickly go through them and see if they can be included or not. So this Rayan makes life so much easier. You click on the leftmost, whatever this option is. To add a new review, you're going to click on this plus sign. Now you go back to your PubMed. All of the results that showed up, you're going to export them as a zip file. So basically, these are the results that showed up. Hold on. "40 results showed up, right? So what I'm going to do is I'm going to click on display options, and I'm going to use, I have a total of 40 results, right? I'm going to make sure that all of those results fit onto one page. So I'm going to use the 200 per page option. Sometimes you're going to have a lot more than 200 studies. Even then you're going to click on the 200. You're not going to get an option of greater than 200, right? So you do that, and then you click on send to citation manager. So what did I do? I basically went on to display option. I selected 200 studies per page. Then I clicked on send to, and then I clicked on citation manager. Once here, you'll see selection all results on this page. You're going to click on all results. You could have had like 1,000 results and only 200 would have shown up on the first page, but you need all 1,000 of them, right? So you're going to select all results, and then you're going to click on create file. It's going to download all of the results as a zip file. Once that has been downloaded, you go back to Rayan.ai. You're going to write your review title. For example, mine is we're using resmetirom for NASH. The review type is systematic review and meta-analysis, but that's not an option here. The description is not really necessary. You don't. It's optional. You can use no. You can click on whatever you want. This isn't very significant. You can choose whatever. Then you click on create new review. Now you're going to select. You're going to upload the files that you downloaded from PubMed. You're going to select file, and the one that you downloaded just now, you're going to upload this, and you click on continue. This is complicated. I'm going to do this again, so don't worry if you don't get the hang of it the first time. So next you click on continue. Now this is the step where you invite members. You're going to add their email addresses in this bar @gmail.com, and they're going to get an email, and they're going to accept the invite, and then they're going to be able to join your review and screen through the studies. I, however, am not doing that right now, so I'll skip. And this is where it shows up, this Metarom for NASH. Now, in the data summary, you'll see, you click on overview. In the data summary, you'll see that you have imported 170 references, 0 duplicates, unresolved. There's no duplicates. If there were any duplicates, it would have shown up here, and then I would have clicked on detect duplicates and then delete duplicates. So this is how you do it, and then you can screen. You can click on screening, and then you can screen as you go. You can either screen, we discussed this, but the primary screening is only done through the title and abstract. You're going to sort about 90% of your studies out. You're going to exclude them because the titles and abstract will not match your PICO. And then for the final stage, the secondary screening, you're going to have to read through the full text. So initially, I'm going to click on screening, and then in the secondary phase of screening, I'll click on full text screening. So if I want to include it, I'll click on include. If I want to exclude it, I'll click on exclude. If I'm not sure, I'll click on maybe. Right? This entirely depends on our PICO. Also, there's studies that are done on humans, and then there's other studies that are done on animals. You can include both. Both are done on living things. Both are original studies. However, if your inclusion criteria is such, you decide your own inclusion criteria. If you want to include studies that are human only, then you're going to exclude all studies that were conducted on animals. However, if you're doing both human and animal studies, then you can include both. So this is how you use Ryan, PubMed, Cochrane, and clinicaltrials.gov. What else did I have to discuss? These are our databases done. Now the last step of today's class is the data extraction. After this class, I'm going to send a meta-analysis, a published meta-analysis on the group. I want you all to read through the meta-analysis before tomorrow's class. So that is before the third day's class, before we do the manuscript writing. So it's going to help you if you read through, because you're going to get an idea of what a meta-analysis manuscript is supposed to look like. So now, for example, let's take any. For example, I had these show up, right? So these are the results that show up. I'm going to click on any one study. This is the one I clicked on. I'm going to scroll down. I'm going to click on the DOI of the original publication, and the original publication is going to open up, which is this one, right? Now I'll read through this, and I'll do the screening and stuff. So when I want to extract data, what I'm going to do is I'm going to make an Excel sheet, or if multiple, because it's a lot more convenient and efficient for at least 2 people to work on the data extraction. You can divide the number of the outcomes. And for example, for this study, when we read through the abstract, we know what when we read through the abstract, we'll get a general idea of what we can expect in this study, right? So the background is going to tell us what the topic is, why the study is being conducted. The last line is always the objective, the aims, for example. Then when we read through the methods, we'll know what kind of studies they've included. For example, what kind of studies included, how many people they've included, what the intervention was, what the control was, everything regarding the methodology, and also the results that they're reporting. So, for example, when we read through this, outcomes is enrolling 700 adults with well-compensated NASH cirrhosis to evaluate the potential of resmetirom to slow progression to hepatic decompensation events. The first outcome is the slowing of progression. Non-invasive tests are assessed, so biomarkers and imaging is also being reported, in addition to validated patient-reported outcomes. Patient-reported outcomes are also being assessed. So once we scroll down, now we have a general idea of what the outcomes are. We will scroll down and we'll get to the endpoints. Endpoints, outcomes, results, all the same thing. This is where you go when you want to find out what outcomes you're going to be reporting and extracting data for. So you will read through these and you will find out what the outcomes are. These are the trials. Sorry, this is actually not a randomized control trial. I'm just trying to demonstrate what we do. Let's just move to a randomized control trial. Hold on. This is the design. This is a randomized control trial. This one is going to tell us what the outcomes are. Okay. So when we're reading the results, we know the methodology and the results. So let's read through the abstract together. Non-alcoholic steatohepatitis is a progressive liver disease with no approved treatment. Resmetirom is an oral liver-directed thyroid hormone receptor beta-selective agonist in development for the treatment of NASH with liver fibrosis. We are conducting an ongoing phase 3 trial involving adults with biopsy-confirmed NASH, fibrosis stage of F1B, F2, F3, blah, 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 blah. Patients were randomly assigned in the 1:1:1 ratio. This is important when you're doing the risk of bias assessment, which we'll study tomorrow. To receive once daily resmetirom, this is our interventions, once daily resmetirom, 1 tablet daily, at a dose of 80 mg or 100 mg or placebo. So these are what these are comparators. So my resmetirom and placebo. And even in resmetiroms, they have two subgroups. One is resmetirom 80 mg daily, one is resmetirom 100 mg daily, and the third group is the control, which is placebo. There are two primary endpoints at week 52. The two primary endpoints at week 52 were NASH resolution. That's our first outcome, including a reduction in the NASH activity score with no worsening of fibrosis. And the second outcome is improvement in fibrosis. So these are the two outcomes that are being reported by this study. So you're going to read through all the studies that you're going to include in your meta-analysis, and you're going to write down the outcomes reported by each study, right? Then you know the total number of outcomes that are being reported by all the studies together, and you're going to divide those outcomes between 2 or 3 people, and then you're going to extract the data for those outcomes. So that's what we're going to do. You're going to have to pay for this. Okay. Let me just. Let's just read literally any trial. Hold on, I need a randomized control trial to. Give me 1 minute. I'll come up with a randomized control trial and I'll make an Excel sheet to show you how we extract data. Okay, sorry. So this is how you extract data. Basically, you have different studies. For each study,
Doctor,
you go
Doc, you are not sharing your
study by
screen.
study. So like one by one, you go through each study, and you're going.
Doctor, You are not sharing your screen.
Hold on. Can you see my screen now?
Yes, we can see your screen.
Can you see my screen? Okay.
Yes,
Thank you for
yes.
letting me know. Okay, so you go study by study, one by one study. This is the data extraction, right? This is not the baseline. For the baseline, we were required to extract the type of study, it was the mean age and stuff that was reported by the study before they started with any intervention or any intervention on the patient population. This is the outcomes. So data for the outcomes. So for example, the first study is Patlola 2022. So the first outcome we recorded was all-cause mortality, but Lola et al. Does not report this outcome. So you skip that. The next outcome is in-hospital mortality, which this study does report. In-hospital mortality, the number of events, so and the total number of patients in the group, in the intervention group, and the total number of patients in the control group. So the basic outline is you have to have a column for the number of events in the intervention group and the total number of patients in the intervention group, and a separate column for the number of events in the control group and the total number of patients in the control group. So, and then the effect size, which could be odds ratio, risk ratio, or hazard ratio, and then the confidence interval. So the first column for in-hospital mortality was the number of events occurring in the exposure group. The next column was the n means sample size. So the total number of patients in the exposure group. The third column was the number of events in the control group, and the fourth column was the number sample size, the total number of patients in the control group. The fifth column was for the effect size. This could have been odds ratio, risk ratio, or hazard ratio. Then we report the confidence interval. The confidence interval is given in brackets, and there's two numbers. So, for example, a confidence interval could be 0.236 to 0.358. So the first one is the lower confidence interval, 0.236, and the second number is the upper range is the upper confidence interval. So this is how you extract data. This is for one outcome. There are multiple outcomes reported by each study. You have to extract data for each outcome from each study. So if a study does not report the outcome, you can skip it. You can leave the column and the cell empty. You can use Excel, Microsoft Excel, or you can use Google Doc. Google Doc is a bit more efficient, more convenient because multiple people can work on it at the same time. So this is how you extract data. This was all that was on the agenda for today's workshop. If you have any questions, please go ahead and ask. Also tomorrow, I am going to send you a meta-analysis right now for you guys to read by day 3. And once we're done with the 3 days of this workshop, you will have 1 week, each of you, to come up with a topic of your own. I'm going to personally look through all of the topics. I'm going to check if they're viable. You have to check if they're viable or not. If they're viable, only then send it in. Then I'm going to check which one's best. The top 3 will be selected for each group, because you guys are going to be distributed in groups of 10 to 12 mentees each group, and a mentor is going to be assigned to each group. The first 2 groups are going to be mentored by me. I'm going to look through, so if there's 10 members, mentees in each group, I'm expecting 10 different topics from that group. I will look through all 10 topics. The top 3 will be selected and sent to Dr. Muaz. Dr. Muaz will then select the best one, and that is the topic that the whole group is going to work on. And there is a very high likelihood that this topic that is selected to be worked on, the person who pitched that idea in is going to get the second or third authorship, because the first authorship is mostly the mentors. But this also depends on how much the mentors are contributing. If we're not able to contribute as much, you guys will get the first authorship. It's all very fair. It's all according to the ICJME guidelines. So, any questions?
Okay, Doc. Like about the data extraction. So, do we need to do this thing manually?
Yes, it's
data
manual
extraction part.
and there is a high margin of error. So you need to check and recheck and recheck again. Because if there's any error in the data extraction, this happened to me once. One of my published meta-analysis, there was an error with the data extraction. The same data was analyzed and it was the results were written, the manuscript was published, and then it had to be retracted and an erratum was put forward. You have to be very, very careful. I wasn't the one who made the mistake, by the way, just to be clear. But this is something very real, and it's you have to be very careful for this.
Okay, that's good.
Any other questions? I'll try to send 1 or 2 exercises on the group so that you guys can practice. I'll send PICOs, and you guys can make search strings and search the 3 databases that I taught you. You can also use Embase and Scopus if you have access to them. And then you guys will report back to me with the number of results that showed up, so that I know you're doing if you're doing the right thing or not. If you're making any mistakes, I'll let you know. If you have any confusions, you can always ask them tomorrow or even after the workshop. We will have 1 to 2 sessions after the workshop ends, so that if you face any hiccup or any hindrance during your project, or if there's anything you're confused about, we can solve it and we can teach you as we go. All confusions will be cleared. So if anyone has any questions now, you can ask them now, you can ask them tomorrow.
So, Doc,
I
it
don't.
would be nice if you can send the PPT. And in case of any
Yes, the PPT will be shared.
okay, and in case of like any queries, can we directly reach out to you?
You can message on the group,
Okay,
because
okay,
I have multiple groups under me, so it will be impossible for me to reply to you on time. If it's on the group, either I can reply to you or any of the other mentors. If you don't get a
okay.
reply the first time, you can pin the same message again. We will make sure to reply.
Sure, sure. Okay.
I do not think there's any more questions. Tomorrow we're going to learn analysis and risk of bias assessment. Tomorrow is the fun part, but also the difficult part. So I'm going to send a link on the group. It's for the software RevMan. You're going to have to follow along with me tomorrow. It's a bit complicated, requires you to be totally attentive. So I'm going to send the link for the software and you have to download it onto your computers. I'll show you how to use it tomorrow. So that's it from my side today. Since there's no more questions, I think we're done for the day. Thank you so much for joining. I hope you learned something. Let's meet tomorrow. Thank you. Bye.
Thank you, doctor, for the awesome explanation and go through. Yeah. Thanks.
Thank you so
No
much.
worries.
Thank you.
You're welcome.